I'm sorry?
Nicolas
Yeah,
is ready.
yeah.
Hi,
Yeah,
how are
I'm
you?
introducing Nicolas, yeah. So it's such a pleasure to introduce Professor Nicolas Perez, who is the head of ENT department in the Clinical University of Navarra in Madrid branch. And Nicolas is one of the leaders in neurotology and vestibular system. I don't think, Nicolas, you may remember, I saw you many years ago when you were in Baltimore.
Yeah, long time ago.
Exactly. And then of course, we met multiple times after that. But Nicolas is also very active in Barony Society. He will be the president of Barony Society in this coming year. And he was the organizer of the current Congress of Barony Society in Madrid, which hopefully is going to happen in future after COVID is gone. But with all that, I want to give the stage to Nicolas, who will give us some excellent talk on Meniere's disease. Nicolas, stage is yours.
Okay, thank you so much for the invitation. And of course, I think we have to remember why we are here. We are here because we are living one of the greatest nightmares anyone can think. All of us who were at the trenches in this fight, we will have always in our heart our friends, relatives, colleagues, patients, and many unknowns that died or have suffered all the stigma of this infection. So I think first we have to remember that we are here because of that. Also, I don't like to see this like a war. I like to see this as a soccer match or a football match. And I think we're going to win. And of course, these small meetings, these small organizations, the effort that looks to be strong for many of us. And I want to congratulate the people from India that they are almost on Sunday right now, and we're still on Saturday. I mean, all these small efforts are small steps, small things that will make us to become greater, and of course, to win this second part of the football match that I think we are almost everyone, we are almost living. So now you asked me about Meniere's disease, and it's hard to make a complete talk. I would like to, I just began to write what I want to speak about, and just to make it a little bit something new, something practical. What's new? I think there are two main new things. That is the identification of the hydrops. That is something we were always were expecting once the patient died, just to make the autopathological report. And now we are able to see that. We can see the hydrops and we can measure the hydrops. That has opened a big field now of what Robert Gurkov has become to call, but it is a very old terminology anyway, is the hydropic inner ear disease. Of course, this means that there's a kind of cochlear or vestibular, or both of them, dysfunction that is linked to a pathological sign, that is the hydrops. It can manifest like with fluctuations in hearing and vestibular. This is Meniere's. It can manifest with a progressive deficiency in hearing and vestibular, or progressive disability. And of course, there's going to be progressive compensation. So I don't want to make the point that hydropic inner ear disease, that hydrops is a pathological sign. So for some disease, we are going to have the symptomatology, we have the pathology, now we see it, and we will have the signs, treatment, or whatever. So I think we're, for the first time, being able to see the Meniere's disease or any other inner ear disease in its proper context, if is there or if there is not hydrops. This is, of course, thanks to the work of many people, but mainly by Professor Naganawa from Nagoya University. In this picture, you can see in your left side This is a guinea pig, hydrops in the guinea pig, experimentally performed, just closing the endolymphatic duct. I did this work. This is back in the 1987 when I was at Dr. Schurneck lab in the Meniere. I was able to do this experiment and to perform the evaluation in histopathology. But it took 3 months from the performance of the surgery until the possibility to see this beautiful picture. In a human, it takes 1 year. Then you can see in your right side the MRI of a patient with a Meniere's disease in her left ear. In the upper part, you can see the midmodular section of the cochlea. This is the autopathological term, that the midmodular section, and you can see almost how you, in this MRI, the contrast will go to the perilymph, but never to the endolymph. So you can see a lot of black dot because that's a hydropic cochlea, and a strong positivity with the gadolinium in the perilymph. You can also see the vestibule, and in tremendous, you don't see nothing but endolymph. You don't see no contrast, so there's no perilymph, and everything is endolymph. In the next section, you can see in the lower part, we are able to see the basal turn of the cochlea with the tremendous hydrops and also the vestibule. This is a very similar view of another patient with another type of section. And of course, we can measure very easily the vestibule. What's new on all this? Well, this is the several patients we were studying in the last 3 or 4 years in our both places, in Pamplona and Madrid. And all these people is people that suffer some kind of fluctuating hearing loss, vestibular or cochlear and vestibular. Let me put you in clear. When in your left side, you see the cochlear, this is typical fluctuating sensorineural hearing loss. And we were able to classify these patients in 3 types. And this comes from the Japanese Society of Equilibrium and Research. And some of these patients do not have any vestibular symptom. Some of them suffer unsteadiness, no vertigo. And some of them did suffer just 1 vertigo spell. And we put all of them there because they were suffering episodes of fluctuating hearing loss. In the middle part, we have patients that suffer episodes of vertigo, some of them without any type of sensorineural hearing loss, and you can call them whatever you want, but they were not migraine, vestibular migraine, please. They were excluded at this time. We used to call benign recurrent vertigo, and that's all what we have. But some of them did have some kind of hearing loss, and this was a fixed sensorineural hearing loss. There was no fluctuation in hearing loss. And then in your right side, you have the cochlear and vestibular type, that is pure Meniere's disease. Which was the amount of hydrops? I'm not going to enter in the details of the amount of hydrops, of how we classify the hydrops, but just it's very easy to see that this is the cochlear, the evaluation of the cochlear, sorry. In white is the percentage of subjects or cochleas in the affected ear without hydrops, and in yellow and black, it means that there's hydrops. So you can see that in patients with Meniere's disease, we have almost an 80% positivity for hydrops in the cochlea with the MRI. But just before, I'm not going to go into the details, but just for example, look in those with the cochlear fluctuation, patients that show fluctuation in their hearing without vestibular symptoms, with unsteadiness or with vertigo. Some of them have hydrops, severe hydrops in black, or a moderate amount that is in yellow. This is a qualitative evaluation. So at some point, we may see that patients that we were not able to call them with any other name or just to ask for any treatment, now we have the possibility to know if there's hydrops. For me, which is the importance of this? Well, I will treat those in the yellow or in the black category with diuretics, and those in the white category just with steroids. So at least I have some indication for treatment. But we also look, sorry, this is the same slide, and this is the evaluation in the vestibular part. As you can see, now there are more colors because we have more ways of evaluating the vestibular system, but almost 90% of patients with Meniere's disease do show some hydrops in the vestibule. This is nothing new, of course, but let's look again to those with fluctuating hearing loss, only fluctuating hearing loss without vestibular symptoms, with unsteadiness, or just that suffer anytime just one spell of vertigo. There's a big amount, almost 50% as a mean of hydrops in the vestibule. So at some point, we are now able to classify our patients with any type of fluctuating symptom in according to the existence or not of hydrops. We did not place at this time only pressure in the ear, tinnitus, because those are symptoms quite confusing now, and we were just trying to exclude that type of patient because there was a complex variability in them, so I'm not placing them here. So as a first idea, now I would say that we are now entering a new time for diagnosis of hydropic inner ear disease, and in particular of Meniere's disease, which is a second new and interesting thing. I think it's the classifications. Of course, radiology needs a framework. We need to have a clear framework of what we are speaking about. So we have a Meniere's disease classification by many years, and I have always followed these three. The Japanese Society, now I have just talk about that. The American Academy in the 1995, and the more recent from the Barani Society. We have some kind of common language. And I would say that the patients that I have shown you with the Meniere's disease were all definite Meniere's disease. Many of the others were probable, but some were not. And I think this is some kind of missing issue in this classification. But anyway, I think there's a lot of work still to be done with the classification, but we have to have a common language, a common way of speaking. So use whatever you want, but use that. It's a very relevant issue. A paper, I think it's 10 years ago, or I don't remember when, that they were able to analyze that very few papers were following the guidelines of the American Academy. They were those guidelines at that time. And of course, I think that makes a big problem that regarding treatments, regarding surgeries, regarding follow-up. So as a matter of fact, now when you read a paper about Meniere's disease, I used to go very soon to the material and methods just to know what are we speaking about. So we have the definite evaluation that is very strict, and as for the notification or the quantification or the documentation of the hearing loss, and we have the probable that is also some kind of more relaxing method of classification. Also, as a summary, I would say that, of course, still we have to keep our clinical identification of the disease, no matter you dislike it. Of course, there's a lot of criticism now regarding the Barani classification. And of course, I will probably be coincident with many of them, of those critics, but I would also like to say that it has a lot of lights. And at least when you mean what is a definite disorder, what is a probable disorder, you are just saying a kind of, well, this is the box where I'm going to place this patient, and it's the box where I'm going to look for those type of patients. Of course, still we have some place for historical ways of analyzing hydrops. The glycerol or furosemide test is a test that we were trained, at least when I was in my residency. It has a low specificity, almost 40%, and low sensitivity of 60% for hydrops. Probably a major achievement was the electrocochleography. It has an 80 84, 85% specificity and almost 90% sensitivity. Here, the problem is how you are going to make this test. Of course, there are a lot of methods. You can go transtympanically, as in this case, using tone burst, or as before, you can go extra tympanic with the electrode on the tympanic membrane, adhere to the tympanic membrane, and just with complex methods of evaluation. Anyway, whatever you use, probably this is the best method for the evaluation of hydrops. Sorry. Wideband tympanometry is a very recent acquisition, and I think it has a lot of work to be done still. And of course, just trying to correlate them with the findings in the MRI is going to be a very surprising work, because of the results are not going to be so easy or so strict as in the case of ECOG, that I think is the gold standard up to now. Autoacoustic emissions were just also thought they should be able to classify them, but it's not so easy. And the champ in the evoke acoustic audiometry also didn't do that well. So sorry, BEMS, the complexity of BEMS makes that this test is hard to perform, specificity is very low. As you can see, it's almost like the glycerol test, and sensitivity is 60%. So in such a way that if we want to be very strict up to now, after clinical diagnosis, if we want to make a diagnosis of hydrops, just to be more detailed in the diagnosis and the treatment, I think that the two methods are more relevant is the ECOG and the MRI. And of course, in my opinion, is best the MRI. Let me tell you that we were doing ECOG at the very beginning of my work, but there were a lot of complexities and we missed that work. We will soon probably begin to do it again. Well, another very relevant issue for me is the differential diagnosis. I think and I just put this title, is Meniere's disease all that looks like Meniere's disease? Yes. And this comes probably for a critic to non-ENT specialist, or working without an ENT or audiology close to you. I'm not going to tell you, of course, that this is a multidisciplinary work, because that is the truth. It's just to say now it's 8 o'clock in Spain, it's night, okay? And it's probably 4 o'clock in the US, and it's the day. And if it is the day, you see the sun. And if it is the night, you see the moon. So it's a kind of, this must be something we don't have to speak about. But still, sometimes it happens. And so it is very easy to say hearing loss with episodic vertigo is Meniere's disease. Well, that's all. Well, that is not all. As ENTs, we for many years were using MRI and just so far to rule out secondary pathologies. We were made to see vestibular schwannoma or even cochlear schwannoma, as you can see here. The lady with the cochlear schwannoma is a very interesting one. She is a person diagnosed for many years with a Meniere's disease, and without almost vertigo spells, after 3-4 years, she lost all the hearing. I mean, she's nothing caphotic at that ear. That is something unusual. We don't see so many caphotic ears in the natural history of Meniere's disease. So we perform a adequate MRI. She came with a central brain MRI, not with a temporal one, and we found that this schwannoma, and this one is growing, as you can see in that red line in the last follow-up. We also found hemorrhagic labyrinthitis, sometimes enclosed or with a misdiagnosis of Meniere's disease, and of course, spontaneous intracranial hypotension less often. But we have to be clear with the differential diagnosis. And for me, those are the main things I have to rule out when I see a patient with a Meniere's disease. Some of them are very common. Some of them are uncommon, but those are the ones we have to see, in my opinion, or at least those the one I have been able to see. Autosclerosis, I mean, this is a very common disorder for any ENT, and there's no way to explain how this is going to appear with the audiometry and tympanometry and stapedial reflex test. And also a good CT scan is gonna, of course, be, or a combing scan or a good CT scan is going to help you. In particular, we have to try to make the differential diagnosis of superior canal dehiscence that is all over the places. But at this point, I think it's going to be the main problem is going to be the differential diagnosis with autosclerosis and the dehiscence. Autosclerosis is a very interesting disease because we see almost an incidence of vestibular symptoms in 20 cities. Are very old statistics going back to 2010. 26% of patients with pure stapedial autosclerosis were suffering vestibular symptoms before surgery. 39% of those with mixed hearing loss, and 50% of those with suspected cochlear autosclerosis. And we were able to see any type of vestibular disorder in patients with autosclerosis. Sometimes there was some BPPV, I mean coincident, chronic dizziness, some vestibular neuritis. And at some point, we were able to see almost a similarity between Meniere's disease and the fluctuation in the autosclerotic patient in their hearing was coincident with vestibular symptoms. So at some point there was a kind of diffuse disorder between Meniere's and autosclerosis. Those most unusual, one is the Cogan syndrome, that at the very beginning could be able to fool us in the diagnosis, but at the end we have to be very careful on the clinical history taking about their eyes disorder or eye symptoms. Susak syndrome needs a very careful assessment of the MRI, but also we need that our colleague in ophthalmology evaluate the fundus, the retina, any particular retinal vascular disorder. Behçet disease, I mean, this is very unusual disorder, but for some reason I was able to see in the last almost 20 years, just 3 of them. The last one was a very recent, and this was a patient that his clinical history, I don't remember right now if it was he or she, sorry, but I remember that in the history there were bouts of or episodes, typical Meniere's disease, but always with a kind of amygdalitis. You know, he came diagnosed of Meniere's and simultaneous amygdalitis, so tonsillitis. Sorry, at some point there was very unusual, and this is very infrequent. So we made a much more strict and in deep evaluation, and he was, or she, I don't remember right now, sorry, diagnosed with a Behçet disease. So these are diagnoses that we have to have in our mind. Probably we are going to see very few of them, but when let me see very few of them, after almost 30 years working in Pamplona, I was able to see almost 170 patients with autosclerosis and vestibular symptoms. That means that there are a lot of them. So at the summary, not all fluctuations in Meniere's disease, according to the MRI, and not all fluctuates is Meniere's disease, sorry, this is MRI, and all that is Meniere's disease is not only Meniere's disease. Will this always be the same? And this is something that takes us to the natural history of the disorder and the importance of time. And probably this is something that I will say is that my major criticism to any guideline is the absence of a staging or some kind of scoring or status evaluation, because Meniere's disease is not always the same. We know that these are the main data. We have to have vertigo, recurrent, spontaneous. It can be positional sometimes. We need hearing loss, tinnitus, and pressure, that all of them fluctuate simultaneously, but This is not gonna be. This is not gonna happen at the end, as you may know. But many times it doesn't happen at the very beginning. This is a work ongoing in our department that I hope it will end up in next years. It's not very easy to be performed because a lot of data was not taken and a lot of patients are not going to be able to be included. So it's a perspective now about when symptoms began. Many times we are seeing patients with a hearing loss, tinnitus, then they develop vertigo, then they develop pressure, and they become to be a Meniere's disease. But regarding when you see this patient, if it's at the very beginning of the hearing loss, there's no Meniere's disease. Or when you see them with just vertigo, it's not Meniere's disease. Just you need all those things together just to say this is Meniere's disease. So we need to take into account time for the beginning and for the end. We know this is a very particular disease that there's a regression to the mean. The number of dizzy spells. This is a very complex slide. Sorry, but in your left upper part, you see the number of dizzy spells according to the years of follow-up. At the very beginning, patients have from 6 to 11, and this is a personal statistics. And then almost 30 years later, it is 3 to 4, many of them, in those not treated surgically. Vestibular function will be degraded with time, but very early. This is on the very first year. There's a lot of the deficiency according to the caloric test, not to the video head impulse test. And hearing loss is going to degrade also with years. And very interestingly, this is a paper we are trying to submit and we don't get to be published. I hope some of the reviewers is here, but regarding the how the pure tone average diminish and the speech discrimination too. In this slide, in this figure, in the upper right upper part, in the black most black curve is a lot of patients for many years follow, and you can see how the pure tone average is going down, 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 and the gray is the speech discrimination score, and at some point the discrimination score becomes lower and lower than the pure tone average. Then the patient begins to feel that he's not understanding the word. I mean, just I do not hear well, but I don't understand, and probably that means that the disorder has become retrocochlear, and this makes an important issue. I think we are trying to build a kind of staging according to hearing loss and to vestibular function, and that will mark for me the last part of the disorder, when now all the symptoms begin to be retrocochlear. And this was also published by Joe Nadel from the Massey and years ago, about how the neurons in the spiral ganglia become becomes damaged at some point, beginning to say that the Meniere's disease now is a retrocochlear disorder. Vestibular function is very important in my opinion, but we know that patients without any type of vertigo spell becomes to be much and much frequent after at least after 10 years. In my opinion, also and we have published how sometimes the video hearing impulse test is normal, but the caloric is not, and that, in my opinion, or at least in what we have seen in the MRI, begins to mark the hydrops is becoming more severe. So it's another way to classify these patients. So I would say that it spends some time on clinical history taking, but many of the details have occurred or are just to come. So I always like to say to my patients when things are not so clear, that let us see in the next 2 years what's going on, because probably if I don't tell you that you have a Meniere's disease now, probably in 1 or 2 years I will tell you that you have that one. What to ask, what to test, I mean, this is a kind of, well, we have to do the whole thing. And I like to, these 4 questions must be always in your notes, must be always on your papers. When did it begin? what is the time since the last dizzy spell? When did everything began to any symptom at the very beginning? Probably it was not Meniere's disease, which was the amount of dizzy spells in the last 6 months. And then we go to the bedside vestibular examination, video head impulse test, the BEMS, caloric, the whole thing. What I'm looking in the bedside test, for me, bedside test is going to tell us uh, the the proximity of the disease spell. You know that nystagmus is going to change a lot, spontaneous and head shaking. Regarding the times in the last disease person, in my opinion, it is going to give us some kind of activity of the disorder. The video head impulse test is going to give us vestibular function. In the combination with the caloric test, will give us some kind of endolymphatic hydrops identification functionally, and of course a great test for the follow-up. The BEMS, I think, are still on the research area, and probably for some kind of treatment protocol, we have to know what is going to happen if you put some kind of gentamicin. Caloric test also, I don't put no gentamicin without having a caloric test before. And of course, audiometry is also good for just to know about the activity of the disorder, as well as disability. So, I mean, not because it's not in guidelines, we have to overlook these things. When I was just surprised with a very recent paper from the American Academy of Otolaryngology, just telling that you have just to make the clinical history and perform audiometry, neglecting any importance for the vestibular test. I mean, there's no way to say this is an completely erroneous statement. So I think we can get a lot of information in this data, but we have to put in our framework and just to classify and follow our patients. And just to end, I would like, there comes the most complex question, how to treat the patient. This is a kind of, I think at this point, any of you probably can give a talk about of this. When you see patient with Meniere's disease for many years, and you see the same patient for many years, you begin to know that many of them are going to end up in endolymphatic surgery or the use of dexamethasone or gentamicin in the inner ear or vestibular laryngectomy. But anyway, the most important time is the initial time of the disorder, when we have to be very conservative. We have to be aggressive. This is not a disorder just to treat and just to give some kind of medication. Then the patient 3 months later comes, tells you, "Doc, I'm fantastic." Probably that is probably the disease that has made a small regression. And even without symptoms, I still like to treat the patient. I tell them, this is forever. This is going to be forever. I'm going to give you some holidays, some month, a year, some time, but don't think that anytime this is defeated. This is a chronic disorder. We don't know why it takes place, so we don't have an etiologic treatment. And this must be, we have to spend the first day, the second, or the third, not more than that, with the patient, just explaining them what is going to happen with the disease, what we are going to treat. But in the very early period, we have to be aggressive on the treatment. But aggressive, I mean, don't stop medication, whatever the patient feels well or does not feel well. I mean, does not feel well, you have to change. But if he feels well, you have to follow with the medication for a long time, for a very long time, and just follow him or her with your evaluation, with your audiometry, with your vestibular testing, or if you can perform MRI just every 2 or 3 years, you can perform one just to see what's happening with the disorder. So I want to stop now. I don't know how I'm on timing, and thanking to the organizers. I think in the case of Sergio and Ashek, I have to say that friendship now becomes to be almost a kind of, I would say, I'm surprised. I'm so extremely happy. I'm great to see that they have come up with this pandemic, just taking us together. So thanks a lot to you and to the other speakers. I've been just coming and going, hearing Dan, Francesco, yes, Jacinto, and of course the audience. It must be very late in India. So thank you for being here, hearing to me. Thanks a lot.
Thank you, Nicolas. Wonderful lecture. Enjoyed, really enjoyed. And there was no question from the audience. There was a compliment. Very nice lecture. Oh, two more came. 1 second. We know that this. I'm sorry.
What is the role of MRI, in your opinion, now, in this moment?
Yeah,
I mean,
it depends. Yeah, it depends on the patient. Of course, if you have a Meniere's disease, a typical Meniere's disease, the chance to have a hydrops is going to be 80-90%. So it's up to you. Probably the role in that patient is low. I would say that those patients are most better evaluated. I mean, spend more time on vestibular testing, on hearing testing. Anyway, the others that do not have a typical Meniere's disease, but you are suspecting some kind of fluctuating, that is the patient. Because, as I said before, the treatment is going to guide my treatment. My treatment according just to use steroids or to use diuretics, or in the case that it is vestibular, other suppressant or whatever, or calcium antagonist or whatever. But another indication, a strict indication for me, is a patient that is going to be treated with gentamicin or with any type of surgery. I have a very bad experience with one patient with a Meniere's disease that it was an autoimmune disease, inner ear disorder, autoimmune inner ear disorder, and we performed an MRI and there was no hydrops, nothing. But he was in 80 dBs in one ear and probably 50 in the other one. So, but he was suffering extreme dizzy spell. So at the end, after any other thing, even steroids, we put gentamicin. He lost the hearing in that ear. So never more I have placed gentamicin without seeing that there is some kind of hydrops. This took to the doctoral the thesis by Pedro Marquez, how he shows that the diffusion of gentamicin in the inner ear depends on the amount of hydrops. If you don't have hydrops, the gentamicin is going to be all over the inner ear. So now, before placing gentamicin, I also perform an MRI. But I would say that in the common patient, in the Meniere's, in the typical Meniere's, you can do it. I mean, it's a kind of interesting issue for the follow-up, but I would say that is the less important for me. And in these statistics, is only 40% of our work. Now we are performing. I will say that I asked my radiologist the other day, Thursday, how many MRIs are we doing for Meniere's disease and how many for the others? And it's almost 70% no Meniere's and 30% Meniere's. I think that is so we are trying to now to put the ECOG just for the Meniere's disease, the typical Meniere's. In that one, you can skip it.
There are a few other questions.
I do. May I?
Hey,
that was great. You got to put another situation in the differential. I just came across recently, and it's the KELCH11 protein antibody syndrome associated with germinomas of the testicle and fluctuating hearing loss, episodic vertigo. They do have neurologic problems too, but that was interesting. And I saw a patient already did have some cerebral signs, but that is perhaps a new antibody that it might need to be considered. And you can have considerably a patient with.
Does it work as a bilateral disorder?
Bilateral.
Okay.
Right.
Good. Thank you.
Yes, that's a. And then one more question: the evolution of the nystagmus, if you were to catch it, that will also be diagnostic, possibly.
Of course.
Very quick. And so, I mean, Miriam probably will be talking about that and so on. But But if one can instruct the patients to video immediately the onset of the attack and so on, then that will be the.
Yeah, in recent common literature, and I want just to stress this to the audience, you are only set to perform an audiometry. I mean, you are suffering a tremendous vestibular disorder, and I have been able to see just very few of them in the spell, but just the day after many of them, you have to perform a vestibular testing, not only audiometry, please. It's just also the vestibular, because in the nystagmus, you're going to find surprising things. Sure.
Okay. There are a few other questions. I think a lot of them you covered
There's a
in
question
between
in
anyways.
Can you see the questions, Nicolas?
Sí.
Can you see the question in the chat?
Okay.
Well,
Yeah.
there is a question about the dissociation between caloric and negative head impulse.
It's very easy. You can go to the Acta Otolaryngologica. We just published a series of patients with the dissociation and with the, it's in the Auris, the increase in hydrops. This is a hydropic disorder, probably in the ampulla of the horizontal semicircular canal, meaning that the hydrops is expanding just to the canals. This is a very unknown thing because of the small structure, but probably is providing an indication that hydrops is becoming at that point. Acetazolamide, this is my teaching. I just trained with David C, and that was Diamox, Edemox, or whatever. It's acetazolamide, sorry. The late Meniere this on other ear affected previously, the worst nightmare after coronavirus. Yes, this is a complex thing. Again, do not hesitate to be extremely aggressive. Steroids at that point, whatever you want, and if you feel you are a skilled surgeon just to perform a intratympanic steroids, do it. If you think that is the time for endolymphatic surgery, well, it's going to depend of the time of follow-up of evolution of the disorder. Probably it's a 30% chance of going well. So against the probability of damage, I wouldn't do that, but it's the only indication right now for the endolymphatic surgery. But I would say be aggressive on the medical treatment and spend in that patient, you have to spend a lot of time doing clinical history at the very beginning of, and this is an experience I have done at the very, very, very beginning of gentamicin. I just treated 7 patients with gentamicin in the second year. They did well, but to the expense of a lot of dizziness, but not so much. They did not did that well. Please treatment. I understand. I always begin with diuretics. I have very unfortunate experience with the betahistine, but that is because I go fast for intratympanic treatments. Is my feeling, and I do a lot of intratympanic treatment. It's where I feel a lot of confidence for these patients. Emmanuel is asking ways to deliver the gentamicin. Well, I just do intratympanic. I just feel the middle ear. Now I use the Max Magnusson syringe that makes a very small or tiny perforation in the tympanic membrane, always heals. But I mean, this is not inject and place it. Just look how the level of the gentamicin goes up in the middle ear, just to cover the whole middle ear. Of course, when you cover a lot, you go to the oval window. That means that you can have a lot of a little bit more of hearing loss, but it's gonna recover probably in less than 1 month. What do I with bilateral menace to my God, migraine, diabetes, and don't respond to treatment because I'm not an option because of diabetes. Well, I ask your endocrinologist first, because many times you are able to do steroids, then you have to go for the intratympanic. However, intratympanic steroids are absorbed, and we have just published one paper with a patient that anytime we put a gentamicin, an injection of steroids, that the sugar, the blood sugar was increasing up and up that night, the next day, and for the next days. It's in a French journal. It's surprising. Whatever you do to any of these patients, just careful look for the blood sugar before and 2 or 3 hours after the injection, and the next day to this patient, they are made to see their blood sugar. No reading this question. Leon Felipe, 23 milligrams. Yes, 23 milligrams per milliliter is the one we use in the. No, dexamethasone. Sorry, we use 23 milligrams. Yeah, it's performed at it's done at the hospital, because there's not a commercially available amount of 23 milligrams of dexamethasone. That is. Sorry for going so fast. You know that I used to go so fast.
Okay, thank you. Gracias.
Bueno, thank you to you, Sergio. Asek, also, I am extremely happy and I'm surprised, and I want to congratulate you again for your big effort with Sudari just to make this meeting possible. And see you tomorrow.